Hello everyone, this is Dr. K here. So today the topic of our discussion is fevers. Fever is a very important topic. Right from first year to all the way to your internship, you will be encountering this several times. So before we begin, what is fever? So fever is defined in two parameters. First as AM temperature and second as PM temperature. So AM temperature of more than 37.2 degrees centigrade, which is measured at 6 AM, and PM temperature of more than 37.7 degrees centigrade, which is measured at 4 PM, is considered as fever. Now, again, one more thing is very important before we begin into this: the conversion of Fahrenheit into centigrade. So the formula is given right here. 9/5 degrees centigrade may whatever your fever is, you add 32 to that, so you'll get your temperature in degree Fahrenheit. Similarly, to get it into degree centigrade, you have to take your temperature in degree Fahrenheit and multiply it by the division of 5/9 and subtract 32 by it. So sites and the peripheral sites give you different readings, so we have to be consistent with the site. Number one. Number two, variation can occur at different sites, which is why we're taking the same site. Now, what are the sites of measurement? The ideal site is the lower esophageal sphincter. If at all you are if you're answering some MCQs, if the options are given, the first option to be marked is lower esophageal sphincter over oral. Number one. Number two is rectal. Rectal gives you the core bodily temperature reading. So 0.4 degrees centigrade or 0.7 degrees Fahrenheit, it is higher than the oral readings. Then we are coming to tympanic membrane. Tympanic membrane measures the radiant heat. If at all your MCQ again comes and asks you which of the following gives you the radiant heat temperature, so you can answer tympanic membrane. Now coming to this, now let's see fever on a scale. I have plotted it here on a scale. So right here from 98 to 99, I have measured the temperature as normal. This is the scale given in degree Fahrenheit. So if we go below this, that is if the patient's temperature is coming as less than 98 degree Fahrenheit and more than 95, this is known as subnormal, all right? But if the patient's temperature is even lower than 95 degrees Fahrenheit, this is known as hypothermia. Hypothermia can occur due to several reasons like myxedema, coma, hypoglycemia, or blood loss. However, since we are studying fever, it's going to be on the higher side. So fever, a temperature of more than 99 degrees Fahrenheit is known as pyrexia. Another word for fever is pyrexia. So temperature between 99 and 106 degrees Fahrenheit is known as pyrexia. However, if the temperature rises more than 106 degrees Fahrenheit, it is known as hyperpyrexia. Now the causes of hyperpyrexia, I have enlisted a few over here, such as malaria, septicemia, heat stroke. Now, menstruating females, their body temperature tends to rise by 1 degree Fahrenheit with ovulation. This is a very important thing to remember, and it remains elevated until the menses occurs in the next cycle. Now, coming next, the elevated core body temperature response to cytokines and acute phase reactants, proteins, can occur in both infection and non-infectious conditions. So fever is kind of a bodily response. It in itself is not a disease. It is a response. It is a symptom. It is a sign. Okay. So whenever we are looking at fever, it is due to increase in body's cytokines and acute phase reactants, and these usually occur in response to what? Infections or non-infectious conditions. Non-infectious conditions can be several, like I have said earlier, heat stroke, or it could be blood loss, hypoglycemia. These all are non-infectious causes. Now coming to the mechanism of fever. So understanding the mechanism of fever is very important in, decoding the patient when it comes to you, when the patient comes to your OPD, as to why the patient is having fever and what is the etiology behind it. So first of all, it can occur in conjunction with increase in hypothalamic set point. So fever occurs in increase in hypothalamic set point. This is a very important point we need to remember, all right? Because we need to differentiate this from other causes of raised body temperature, which we'll be coming to shortly. So there are three mechanisms. First, there is heat conservation. Second, heat production, and behavioral adjustments. So heat conservation occurs how? By subcutaneous vasoconstriction. So the peripheral blood vessels, they constrict so that the blood flow can be redirected to your vital organs, such as your heart, your livers, your kidneys, basically your vital organs. Now heat production. Heat production is through shivering. So your body is trying to produce heat by shivering, and non-shivering thermogenesis. So these are two mechanisms. Now coming to behavioral adjustments. So since we're human beings, we can bring about certain changes in our environment, in our behavior, so that we can produce heat, such as wearing warm clothes or moving indoors to a warmer place. All right. So, along with those asks about it. So coming back to the mechanism. So later what happens is, first we've talked about this mechanism occurring through these three, that is heat conservation, heat production and behavioral adjustments. Later when hypothalamic set point, it becomes reduced. First the hypothalamic set point is increased, later it will be reduced. Since the body has already produced such heat, now it has already attained what it had to. So it will later reduce the body temperature, because at higher temperatures the proteins can undergo denaturation, which is also not desired by the body. So later the hypothalamic set point will reduce. So how does this occur? The right opposite of all these three, that is vasodilation. Over here we have talked about vasoconstriction, subcutaneous vasoconstriction. Over here vasodilation will occur. Sweating, okay? So here heat production was happening through shivering. The right opposite of this is sweating. And again, behavioral adjustments. Over here we were wearing warmer clothes. Over here we'll start removing those warm clothes to cool off our body. Next, let's understand the difference between hyperpyrexia and hypothermia. Hyperpyrexia. So what is the mechanism of these two? First of all, hyperpyrexia, there is an increase in the hypothalamic set point where the PGE2 increases, that is prostaglandin E2. Then hyperthermia, what happens is the hypothalamic set point is normal. That means the patient is normothermic, very important. All right. Then coming to the values. So in hyperpyrexia, the temperature often rises up to 106 degree Fahrenheit, 0.7 degree Fahrenheit. That is 41.5 degrees centigrade. Over here, the temperature is more than 40.5 degrees centigrade. So hyperpyrexia, the temperature is slightly higher. Then sweating is present in hyperpyrexia, but it is absent in hypothermia. Why is that? Because the patient is normothermic. The hypothalamic set point is normal. Coming to the skin is often cold skin because there is subcutaneous vasoconstriction happening here. There is decreased blood flow. Over here, the skin is hot and dry. Why is it hot and dry? Again, because hypothalamic set point is normal. Causes can be microbes, toxins, CNS hemorrhage. Over here, the causes can be heat stroke or increase in heat production by muscles. Treatment is often done by treating the underlying cause or NSAIDs. Over here, in hypothermia, it is very important that we immediately provide patient with water therapy. Now coming to the pathogenesis of fever. Pathogenesis of fever is very important again. Fever is often caused by pyrogens. Pyrogens are any substance that cause fever. Easy to remember, all right? Now, pyrogens are of two types. There are exogenous pyrogens and endogenous pyrogens. As the name itself says, exogenous stands for pyrogens coming from the outside. However, endogenous pyrogens are produced within the body. So, fever-causing substances that are coming from outside, these can be microbes or it could be their products. Example, gram-negative bacteria, gram-positive bacteria, Staph aureus, etc. So these are infections, inflammation, immune reactions, etc. All these things leading to monocytes, macrophages and endothelial cells production. The production of these further leads to pyogenic cytokine production. These cytokines include interleukin 1, interleukin 6, tumor necrosis factor, INF, etc. And these enter the circulation. And through the circulation, they will reach the hypothalamic endothelium. Once they reach the hypothalamic endothelium, they will release PGE2, and this PGE2 production will cause cyclic AMP to be produced. And right here, microbial toxins will also help in stimulating the hypothalamus. Okay. This will again produce PGE2, again leading to the production of cyclic AMP. This will elevate the hypothalamic set point, leading to heat conservation. This will lead to the elevation of hypothalamic set point. Heat conservation will occur, heat production will occur, and fever will be produced. Similarly, in endogenous pyrogens, cytokines will be produced right here. So these cytokines are being induced. The production of these cytokines are being induced over here. Ultimately, they are only causing the fever, but in exogenous pyrogens or exogenous causes, these causative organisms will trigger the production of cytokines. Right here, they are being produced on its own. The cytokines produced are interleukin 1, 6, TNF alpha, ciliary neutrophilic factors, and these may be induced by, again, fever, bacteria, fungi, virus, and non-infective causes such as pericarditis, trauma, stroke, or vaccination. Next, coming to the approach to fever. So approach is essentially very important when coming to any disease or any symptom, or coming to any patient when the patient presents to you in your clinical scenario. So whenever a patient presents to you in a clinical scenario, how do you approach the patient? First of all, you listen, as soon as the patient walks in, you look at them. Second, you ask them for their clinical features. Third, you perform a clinical examination, a physical examination, you perform lab tests, and later you give them management. So this entire journey, right from the point the patient walks into your OPD to the point when the patient is completely considered treated or cured, you have to take a holistic approach to the patient, and this is known as the approach to patient. So first point is physical examination. So whenever a patient comes to you with fever, the first thing we need to do is take the body temperature, and make sure you always take it from the same site. Number two, look for active infections in absence of fever, or maybe present in newborn or elderly, chronic hepatic or renal failure patients, or patients on glucocorticoids or anti-cytokine therapies. Now this is your physical examination. Besides this, the lab tests. In lab tests, patients, what you have to send is CBC with differential count, which will usually come as elevated, but neutrophils may be seen. Now neutrophils are often seen in acute infections and bacterial infections, so you can again have a direction as to what the patient has. Number two, you will send the patient to have ESR and CRP elevation. In low-grade fevers or occult diseases, these are often increased. Next, now patient if on cytokine therapy, take an example on a patient with latent M tuberculosis, or can disseminate into patients with active TNF therapy, or Crohn's disease, rheumatoid arthritis, or psoriasis. Low-grade fever is also a considerable concern. Now coming to the management or treatment of fever. So mostly fever is a self-limiting disease because most common causes of fever are viral causes. Objective of treatment is to decrease the hypothalamic set point and facilitate heat loss, which were primarily the mechanisms of fever. We are trying to aid in that. Now coming to drugs. So acetaminophen is the most commonly used drug, which is also known as PCM. Then we can also give patient aspirin or NSAIDs. Aspirins are to be avoided in children as it can cause Ray's syndrome in children. Increase in oxygen demand occurs during fever. For every 1 degree Celsius rise above 37 degree, there is more demand of oxygen. So oxygen demand increases by 13%. All right. Now coming to the patterns of fever, these are essentially very important. However, they are of less clinical importance in today's world. Whenever the patient is coming to you, they will most likely would have taken a dolo or a PCM or some form of antipyretic. So they may not be able to tell you the exact pattern of fever. However, for your clinical knowledge, this is very important. All right. So we have several types of fevers. First, let's talk about continuous fever. So continuous fever, I have represented here, as you can see this line, purple colored line as it's going. So baseline is never touched in continuous fever. The fluctuation of fever is less than 1 degree centigrade. So what is continuous fever? The baseline is not touched and the fluctuation is less than 1 degree centigrade in 24 hours, as we have plotted. Examples of continuous fever are bacterial meningitis, gram-negative pneumonia, or typhoid. These are some of the examples of continuous fever. Now coming to intermittent fever, I have represented here with green. So the fluctuations you can see, the baseline is often touched. The baseline is here. This green colored highlight is the baseline. So it is touching the baseline, it is going up, it is touching the baseline. All right. So intermittent fever, the causes can be malaria, tuberculosis, etc. Coming to remittent fever, which is represented here in the pink. So baseline is again not touched. It is above this green color highlight you can see. And the fluctuation is more than 2 degrees centigrade. Here the fluctuation was less than 1 degree centigrade. Here the fluctuation is more than 2 degrees centigrade. The examples of remittent fever are infections such as endocarditis, rickettsia, brucellosis, etc. Now coming to the intermittent fever, let's elaborate a little bit more on this since it's very important. Now intermittent fever is again of 4 different types. It is tertian fever, it is quadrant fever, it is quadrian fever and palpabstine fever. Now tertian fever, the periodicity of tertian fever is 48 hours. That means the fever is coming on every 48 hours. So there will be fever on the first day, there will be no fever on day 2, there will again be a fever on day 3, no fever on day 4, and similarly the pattern follows. So the periodicity is 48 hours. Examples of this is P. falciparum, Plasmodium falciparum. Quadrant fever, the periodicity is 72 hours. In 72 hours, the period will reoccur. For example, the patient has fever on day 1, then there will be no fever on day 2 and 3. Again, the patient will have fever on day 4. Similarly, the pattern follows, and the example is Plasmodium malariae. Quadrant malaria periodicity is 24 hours. So the patient will have fever on every day, but once a day. There will be one spike per day. Example is mixed falciparum and vivax. Next type of intermittent fever is palpabstine fever. Palpabstine fever, there is fever for 3 to 10 days, followed by 3 to 10 days no fever. That is known as afebrile phase. So in this fever, there is febrile phases followed by afebrile phases for 3 to 10 days, then again febrile phases for 3 to 10 days, and so on. The example of this type of fever is Hodgkin's lymphoma. These are the 3 types of fevers. Now coming to the 4th type of fever, that is the relapsing fever. Relapsing fever, there are 2 febrile episodes and can within a febrile episode seen within between these 2. So there is an febrile episode and a febrile episode, and there is going to be an afebrile episode between these 2. So the example of this is cyclic neutropenia, when this fever occurs on day 21 with neutropenia. It is often seen in malaria and lymphomas. Now coming to the causes of fever, so there is a mnemonic over here, that is vitamin D. We can remember the causes of fever through this. So V, vascular, that is DVT, pulmonary embolisms are causes of vascular causes of fever. Coming to infection, that is viral infections, bacterial infections, fungal infections, protozoal infections, and so on. Then traumatic, that is fat embolisms, crush syndromes, then these can also lead to elevated body temperature. Autonomic causes such as SLE, systemic sclerosis. M for metabolic, that such as gout. I for idiopathic, so idiopathic has no causes. Those are unknown causes. Coming to neoplastic, we have lymphomas and leukopenias. Then D for drugs. Drugs such as allopurinol, antihistamines, barbiturates, antibiotics like penicillin, cephalosporins, analgesics like salicylates. These all can cause elevated body temperature or fever. Now, another very frequently asked topic or question in your vivas, in your exams, is pyrexia of unknown origin. So what is pyrexia of unknown origin? This refers to any febrile illness with or without an initially obvious etiology. Now again, the fever of unknown illness is defined as these 4 points. Whenever your examiner is asking you, you must recite these 4 points to get full marks. So fever of more than 38 degrees centigrade or 101 degree Fahrenheit on at least 2 different occasions, number 1. Number 2, fever for more than 3 weeks. No known immunocompromised state in the patient. Number 3, diagnosis that remains uncertain even through history, examination, and investigation. So these are the some points that you need to remember in fever of unknown origin or pyrexia of unknown origin. Now another very important question is relative bradycardia. These are this is only important for your viva purpose or maybe a certain MCQ. They may not be asked in your theoretical exams. So first week of relative bradycardia, first week of enteric fever, there is relative bradycardia. Then brucellosis, leptospirosis, dengue, typhus, Q fever, non-infectious causes such as patient on beta blockers, drug infections, factitious fever or lymphoma.